Hello everyone, good evening and welcome to this session of ENT. I am Dr. Vyshnavi, your ENT faculty on the Unacademy platform. I hope I'm audible and visible to all of you. If it is there, please let me know quickly in the chat box so that I'm having a confirmation from your end that the relay is going on well and we can start off with the class. Yeah, so quickly, if I can have a confirmation from those online, it will be great so that we can start off the class. Good evening, Medico. Good evening, Rohan. So I think all is going good. Yes. So, now we are going to discuss some of the very high yield topics. Basically, it's not going to be a topic or theory kind of a discussion. But basically, I'm going to give you MCQs for discussion, which will help you get yield of all those highly important topics which we are expecting or anticipating in the examination. So that somewhere you are close to those topics which are previous year's questions and the topics which I feel are quite important for your exams. So with this, let's get started. You have a question over here which says that there is a 30-year-old female patient who presented with the following clinical finding. She reports that it has been like this since birth but has worsened since the last few weeks. What is this deformity called as? Is this called as a deviated nose? Is this called as a saddle nose? Is it called as a crooked nose? Or is this a hump nose? So you can quickly message me in the live chat as to what do you think is the answer. Yeah. So the answer for this is some of you are mentioning it as DNS, some of you are mentioning it as crooked nose, some of you are mentioning it as hump. Okay, so basically, whenever we talk about nasal deformities, you need to know some important points here about nasal deformities. There are two types of nasal deformities. The first one is called as a saddle nose or the hump nose, which are midline deformities of the nose. And then you have got the crooked nose and the deviated nose, which are the deformities of your lateral wall or the dorsum of the nose. So the first thing that you need to look is this a saddle nose or a hump nose? So for a saddle nose or a hump nose, what we have to look for is on the dorsum of the nose in the midline, is there any excessive projection or is there any excessive depression? Now, if there is any excessive projection on the dorsum of the nose, we would call this deformity as a hump nose. But if you have a depression on the dorsum of the nose, this deformity will be called as a saddle nose deformity. Okay, so these are midline deformities where you can have excessive projection or a depression. Now, this is a deformity where the dorsum of the nose is shifted or deviated. So this is not saddle nose or hump nose for sure. Now, in the lateral nasal deformities, you have to check 2 points. The first one is called as the nasion. Nasion is the point where the frontal bone articulates with the nasal bone in the midline. We call this as the nasion. Okay, and this here is the tip of the nose. So here this thing is the tip of the nose. Now, if the nasion is in the midline, and the tip is also in the midline. So nasion is in the midline, and also the tip is in the midline, but rest of the dorsum has got deviated like this. Then we call it as a crooked nose. So nasion in the midline, tip is also in the midline, but the rest of the dorsum has got shifted. We call it as a crooked nose. But if the nasion is in the midline, but the tip has got shifted, then we call it as a deviated nose. So nasion is in the midline, but the tip has got deviated, then we call it as deviated nose. Now here we have a deformity where the nasion is in the midline, tip is in the midline, the rest of the dorsum is deviated, and hence this comes under the crooked nose deformity. So the answer for this question is crooked nose deformity. Now, what do you do with the hump nose deformity? क्या है इसका treatment? The treatment for the hump nose deformity would be to remove that excessive hump. तो remove करने के लिए what do we call that surgery? We call that as a reduction rhinoplasty. Okay. And if there is a saddle nose deformity where there is excessive depression, you're going to cover it up by covering it up by augmenting. That is called as augmentation rhinoplasty. So here what you do is augmentation rhinoplasty. For deviated nose or crooked nose, you are going to do a septorhinoplasty. So septorhinoplasty will be done for deviated nose and as well as crooked nose. So I hope all of you got the understanding of the deformities of the external nose in one MCQ. Okay, let's go to the next question. External nose is made up of an upper bony part and a lower cartilaginous part. The lower cartilaginous part in turn has got a few paired and a few unpaired cartilages. Which of the following is unpaired? The upper lateral cartilage, lower lateral cartilage, lesser lateral or quadrilateral cartilage. So which of them is an unpaired cartilage? So if you know the external nose anatomy, it's going to be pretty simple for you to answer this question. Okay, so I'm getting the answers. Satisha says quadrilateral. Medico says CC. What is CC? I didn't understand. Ayan Das also says D. Okay, so if we take the anatomy of the external nose is made up of a bony pyramid, which is made up of the nasal bone, which are paired, ascending process of the maxilla, which are again paired, and the frontal bone from above, which is an unpaired structure. So nasal bone, ascending process of maxilla, these are paired bones. The unpaired bone is the frontal bone. Now we have got some cartilages also. So what are the cartilages? We have got the upper lateral cartilage. We have the lower lateral cartilage. We have the sesamoid cartilage. All these three are paired. So upper lateral, lower lateral and sesamoid are paired cartilages, and the septal cartilage or the quadrilateral cartilage comes from below to support the dorsum of the nose. That's an unpaired cartilage. So the question is asking which is an unpaired cartilage. So the unpaired cartilage on the dorsum of the nose or in the external nose is going to be your quadrilateral cartilage. Rest of the three, the upper lateral, lower lateral and sesamoid are paired cartilages. So I think this is also very clear to all of you. Now let's go to the next question. A patient presents to you with hoarseness of voice. The structure given below is most likely damaged. This structure is lined by what kind of epithelium? So if you see, they are pointing towards one structure. What is the lining epithelium of this structure? Is this non-keratinized stratified squamous epithelium, pseudo-stratified squamous epithelium, stratified squamous but keratinizing type of epithelium, simple columnar epithelium? So what do you think is the answer for this question? Yes, I'm waiting for the answers. Yes, I can see the answer by Kiruba is A. Seth Plus says A. Okay, so the correct answer, yes, is A. So if you see, the structure that has been marked is vocal cord. Now, vocal cord is a part of your larynx. It's a part of your larynx. Larynx is a part of your respiratory tract. Okay, so it's a part of which tract? Not the digestive tract, but your respiratory tract. Now, respiratory tract should be lined by what type of epithelium? From our nose to the terminal bronchiole, we have got, ciliated columnar epithelium. So we have got ciliated columnar epithelium that lines the entire respiratory tract, except for a few sites. What are those few sites which is not lined by ciliated columnar epithelium? The first one is the lingual surface of epiglottis. So epiglottis has got two surfaces, the one facing the base of tongue and the one facing the larynx. So the one facing the base of tongue is called as lingual surface of the epiglottis. The second part is your vocal cord. So vocal cord is another area which is not lined by pseudostratified ciliated columnar epithelium. It is lined by simple or non-keratinizing stratified squamous epithelium. So the take home point is, remember the exceptions of what are not lined by columnar epithelium in your respiratory tract. Okay, so that completes the question. Let's go to the next question. All the following procedures can be done using the ENT instrument given below, except removal of non-hygroscopic foreign body, instillation of medications, examination of the tympanic membrane, identifying the mobility of the eardrum. Now, this is again a very simple question. ये instrument हर ENT surgeon के OPD में रहता है. So, if you have attended any of the ENT sessions in your hospital या कहीं पे भी, you will be able to answer this very easily. So I'm waiting for the answers. इसको क्या कहते हैं? So this is called as Siegel's pneumatic speculum. So इसका क्या use है? What is the use of the Siegel's pneumatic speculum? So basically, if you see, there is an oral speculum. So this oral speculum, we have got a tubing, rubber tubing attachment that gets connected via a eyepiece. This eyepiece gets connected to the speculum, and then there is a rubber tubing, and this is your rubber cuff. Now, what do we do here? Now, here in the external auditory canal, we place this speculum. Over this, we put the Siegel's pneumatic attachment. Now, whenever we want to see the mobility of the tympanic membrane, we will increase the pressure or decrease the pressure. So, I will inflate and deflate the cuff. As a result, the pressure in the canal will increase and decrease. Now, whenever the pressure in the canal will increase and decrease, the tympanic membrane will move. Like it will either go inward and outward. With positive pressure, there will be an inward movement. With a negative pressure, there will be an outward movement. So, you will see movement of the tympanic membrane if the middle ear is healthy. So you will see good movement of the tympanic membrane. This test where you see the motility or mobility of the tympanic membrane, we call it as Siegelization. Now, if there is any middle ear disease or there is a retraction of the tympanic membrane where it is adherent to the promontory, there will be reduced mobility or sometimes even no mobility of the tympanic membrane. So, is it done to examine the tympanic membrane and also for mobility of the tympanic membrane? Of course, yes, that's one of the primary reasons why we do this Siegelization. What is another reason why we do this Siegelization? Now, the next reason why we do Siegelization is also for instillation of drugs. So if I put a powdered medication in the outer part of the ear and I inflate the cuff, that pressure will push the medication and this will go and get dispersed into the external auditory canal and the tympanic membrane because of the pressure, because of the air puff that comes in, that will go and get dispersed. So we can administer powdered medication. So for administering powdered medication, we can do this. The third use of this procedure is also for doing a test which is called as fistula test. What is fistula test? Basically, a fistula test is used to identify if there is any communication between the middle ear and the inner ear. So whenever there is a communication between the middle ear and inner ear, the pressure goes from the middle ear to the inner ear to cause vertigo and nystagmus. But if there is no communication, there will be no vertigo and nystagmus. So to identify whether there is a communication, we do this fistula test. But is there any role of this instrument in removal of foreign body? Unfortunately not. So the answer is removal of foreign body is not one of the uses of this instrument, which is Siegel's pneumatic speculum. Okay, so I think this is clear to everybody. Hello, Irfan. Let's go to the next question. A patient presented with hoarseness of voice and dysphagia. So what are the symptoms? Hoarseness of voice and dysphagia. Laryngeal carcinoma is suspected after clinical examination. After necessary investigation, she was diagnosed with malignancy of the infrahyoid epiglottis. If this condition is left untreated, this may metastasize to which of the following location? Subglottis, thyroid cartilage, pre-epiglottic space or the nasopharynx? Again, a very simple question. Very good, Pratishtha, sorry. So if we take this as the larynx and this as our epiglottis, this space that lies in front of the epiglottis, this space is called as the pre-epiglottic space. Now they have specifically told you there is a carcinoma of which part of the epiglottis? The infrahyoid epiglottis. So this is your suprahyoid epiglottis and this is your infrahyoid epiglottis. So there is no true demarcation. It's an imaginary line that passes through the hyoid bone. Now, if there is a lesion in the infrahyoid epiglottis, would it go to subglottis as the first metastatic or lesion, or would it go to the thyroid cartilage, or would it go to the pre-epiglottic space or to the nasopharynx? Which one is the most adjacent space where it can spread? Of course, it will go earliest to this space, and that space in front of the epiglottis is called as pre-epiglottic space. Now, I have a question to all of you. There is a name given to this space. Pre-epiglottic space is also called as space of dash. So anybody can tell me in the chat box what is pre-epiglottic space also called as? So pre-epiglottic space is equal to space of dash. Similarly, there is also a space that is also called, that is around the larynx. This is called as paraglottic space. And paraglottic space is also given a name. What is that? Space of dash. Very good, Himanshi and Preetham Kumar. Pre-epiglottic space is called as space of Boyer. Paraglottic space is called as space of? Yes, I'm waiting for the answers. It is called as space of Tucker. There are three spaces in relation to larynx: the pre-epiglottic space, the paraglottic space, and the third one is Rinke's space. So Rinke's space is a subepithelial space which you see usually under the microscope. So these are the three spaces that you should definitely know of. Okay. No, Pritam, it's not Versang. It is called as space of Tucker. Okay. So I hope everyone understood this question. Let's go to the next one. An elderly male presented with severe epistaxis. He also reports that he cannot breathe through his nose. Why can he not breathe through his nose? Rhinoscopy had showed that there is a mass in the lateral wall of the nose. That's why he is not able to breathe. Tissue pathology is showing you something like this. What is the most likely diagnosis? Ringer's tumor, osteoma, nasopharyngeal carcinoma, or foreign body? So this is very, very typical HPE finding that you see in a common lesion. So can you tell me what are we discussing here? Yes, I am waiting for the answers in the chat box. What is your diagnosis? Ringer's tumor, osteoma, nasopharyngeal carcinoma, or foreign body in the nose? Very good, Preetham, Pratishtha, Ayan Das, very good. So if you see in histopathology, you see that the epithelium or the superficial epithelium is running towards the stroma. It's not going towards the surface, but the papilla are inverted. So these finger-like projections that are coming from the epithelium are not growing towards the surface, but they are growing inwards towards the stroma. So that is why this tumor is named as inverted papilloma. So this is a typical histological feature where you see the papilla or the finger-like projection growing inwards. So inverted papilloma is a benign tumor or a malignant tumor? Quickly. I'm waiting for your answer. Is it benign or is it malignant? In the chat box, I need. This is also called as Ringer's tumor, transitional cell tumor. It is also called as Schneiderian papilloma. So can anybody tell me, is this benign or malignant? Very good, Pratishtha. It is a benign tumor. But is this going to be pre-malignant or not pre-malignant? Yes. So this is called by different names. It's a benign tumor, but is it pre-malignant or not? Good. So yes, there is a high risk of malignant transformation. So it is a pre-malignant condition. Now, what is this inverted papilloma caused by? Most commonly caused by which virus? Which virus is implicated in causation of human, inverted papilloma? I just said one alphabet. It is HPV. Okay, so human papilloma virus is usually attributed to causing this disease. Now, this is a benign tumor, pre-malignant tumor, and sometimes the lesion can be associated with malignancy, presents to you with difficulty in breathing and also bleeding from the nose. So, on examination, they might look like a polyp to you, but if bleeding is a manifestation, don't think of a polyp because polyps don't bleed. So if it is a bleeding tumor, think about inverted papilloma arising from the lateral wall of the nose. It is diagnosed by CT and MRI, and the treatment for this condition is medial maxillectomy. So medial maxillectomy has to be done. This can be done endoscopically or with external incision. So medial maxillectomy is the treatment of choice, either endoscopic or external. One of the two approaches. Commonly that we do is endoscopic because it avoids the scar. So this answer to this question is Ringer's tumor. So I hope you learned everything about inverted papilloma in this MCQ. Great. Now let's go to the next question. A patient presented with new onset hoarseness, changes in the vocal pitch or noisy breathing. He underwent a surgery to repair an aortic aneurysm few days back. So please see, there is one very important hint given that there is a repair of aortic aneurysm that was done a few days back. Which of the following is most likely to have been damaged during surgery? So what structure has resulted in the symptoms of hoarseness, pitch of the voice is changed, and there is noisy breathing? So what do you think? Left recurrent laryngeal nerve, internal, external, none of the above. See, now one thing you have to remember is they have given you a linked finding that there is an aortic aneurysm repair. So they have done some procedure in the mediastinum. After that mediastinal procedure, this symptom has resulted. Now what now will go into the mediastinum? Is it the recurrent laryngeal nerve or the superior laryngeal nerve? Yes, we know that only the left recurrent laryngeal nerve travels in the mediastinum. So following any injury to the left recurrent laryngeal nerve, the patient can have noisy breathing, the patient can have mild change in the voice, usually not major change, because major change in the voice is usually due to injury to external branch of superior laryngeal nerve. So here we can attribute this mainly to the left recurrent laryngeal nerve, because rest of the nerves, whether it is internal, whether it is external, or the right recurrent laryngeal nerve, do not travel in the mediastinum at all. So the possibility of them getting damaged after aortic aneurysm surgery is bleak. Hence, our answer will be left recurrent laryngeal nerve. Okay, let's go to the next question. Bloom-Singer prosthesis for voice rehabilitation is used in total laryngectomy, near total laryngectomy, hemilaryngectomy, none of the above. So this is also a very common repeat question. They give you either an IBQ or they can give you a direct question like this. So Bloom-Singer prosthesis for voice rehabilitation is used in which condition? Okay, so Pritam Kumar says C. What about others? I'm waiting for your answers. See, whenever we have to do voice rehabilitation, there is a general rule. If any part of the larynx or any part of the, any structure in the larynx is left behind after surgery, that can still vibrate and can be used to produce voice. So until you do a total laryngectomy where you remove all the components of the larynx, the voice will be lost and then you have to rehabilitate. So if we are doing a near total laryngectomy or a hemilaryngectomy, we have still some portion of the larynx that's left behind. And since some portion of the larynx is left behind, there is always a possibility that can be used to vibrate and produce voice. May not be normal voice, but yes, they can have voice. Rehabilitation will be done only when you do a total laryngectomy. So after total laryngectomy, voice rehabilitation can be done using three main ways. The first one is called as a esophageal speech. The second one is called as tracheoesophageal speech. First one is esophageal, the second one is tracheoesophageal, and the third one is called as electrolarynx. Now, when we talk about tracheoesophageal speech, you make a communication between the trachea and the esophagus. So here this patient will be on a permanent tracheostomy. There is no larynx, and the patient's trachea is now connected to the upper esophagus. And whenever the patient wants to produce speech, the air current gets redirected through the prosthesis to the upper esophagus. It vibrates against the cricopharyngeal sphincter. Acoustic waves are produced. They go through the articulators to produce speech. So that prosthesis that we use here between the trachea and the esophagus is called as the tracheoesophageal prosthesis. This tracheoesophageal prosthesis can be of many types. Bloom-Singer's prosthesis, Provox prosthesis, etc. So if the question is voice rehabilitation, it has to be after total laryngectomy. We do not rehabilitate after near total or hemilaryngectomy because there is no need for doing so. Okay, so I'm sure all of you got it by now. Now let's go to the next question. Static equilibrium is a function that can be attributed due to macular function, organ of Corti, crista ampullaris, or the cerebellum. So who or which receptor in your inner ear is responsible for static equilibrium? I'm waiting for your answers. Yes, very good. Pratishta, Pritam Kumar, that's the right answer. The macula is the answer. So if we take here the inner ear structure, we have in the inner ear a central chamber which is called as the vestibule. Anterior to the vestibule, we have got the cochlea, and posterior to the vestibule, we have the semicircular canals. Okay, now in the utricle and saccule, we have got sensory neuroepithelium, which is responsible for hearing and balance. And that sensory neuroepithelium responsible for hearing and balance is called as macula. Similarly, in the ampulated or the dilated end of the semicircular canal, there is a sensory neuroepithelium. This sensory neuroepithelium that is there in the ampulated end of the semicircular canal is called as crista. And the function of crista is only balance. It has nothing to do with hearing. Similarly, in the cochlea, there is a sensory neuroepithelium. This is called as organ of Corti. This organ of Corti is responsible only for hearing. Now, if you see the question, they're asking to you something related to balance, which is static equilibrium. So, can I easily cut off organ of Corti because it has got nothing to do with balance and it is only responsible for hearing? Yes. Now, there are two receptors in the inner ear for balance. One is crista, one is macula. Now, only for angular motion or rotational motion, you are going to have crista that is going to function. So, what is the function of crista that is responsible only for angular motion? But for all the other functions of balance, whether it is linear acceleration, deceleration, position of head against gravity, static equilibrium, or any terminology that even you don't know of, simply mark macula. So for all the major functions of balance, it's the macula. Only for angular rotational motion, it is the crista. So crista is also not there. It is due to macula. Cerebellum will only coordinate. It is not responsible for sensing the movement. Sensors for movement are only macula and the crista. Angular motion by crista, rest all by macula. So the answer is macula. Okay, let's go to the next question. Sign of acute laryngotracheobronchitis is thumb sign, stipple sign, vallecular sign, none. This is again a very easy question which you tend to see in every examination. I'm waiting for your answers. Thumb sign, steeple sign. Very good. All of you are right. Thumb sign is a sign that you see in acute epiglottitis, and acute epiglottitis is a bacterial infection. Okay, so it's a bacterial infection. Steeple sign is a sign that you see in laryngotracheobronchitis, and here you see this on an X-ray on an AP view, on an anteroposterior view, whereas this you see in a lateral view X-ray. So the sign that you see in acute laryngotracheobronchitis is your steeple sign. Okay. During inspiration, maximum current of airflow in the normal nasal cavity is in which part? Upper part in a parabolic curve, middle part in the parabolic curve, through the olfactory area, or through the lower part of the cavity in a parabolic curve. Again, a very basic question this is. So during inspiration, where do you see maximum volume or maximum current of air flowing through? So whenever we breathe, the maximum volume or maximum inspiratory current comes from the anterior part or vestibule of the nose, goes to the middle meatus. So this goes to the middle part of the nose or to the middle meatus in a parabolic curve. So maximum volume or maximum current of airflow goes in which part? In the middle part or the middle meatus in a parabolic curve. So maximum air current is in the middle meatus. During expiration, what happens is air current are flowing from the larger choana to a smaller vestibule. So expiratory current comes from a larger choana to a smaller vestibule, and here in the vestibule you have a valve called as the internal nasal valve. This internal nasal valve is the narrowest portion of the nasal cavity. And now when the air current flows from the choana to the vestibule at the level of internal nasal valve, circular currents are established, and these circular currents are called as eddies currents. So eddies currents are established, and these eddies currents will help in ventilation of the sinuses. So if you see, the maximum volume is going during inspiration in which part? In middle meatus in the parabolic curve. Expiratory current will usually result in eddies currents. These eddies currents will push the air into the paranasal sinuses and help in ventilation of the paranasal sinuses. Okay, now let's go to the next question. A patient is planned for auditory brainstem implant. What is the site for location of the placement of implant? Cala tympani, recess of the fourth ventricle, internal auditory canal, behind or back of the ear. Yes, Chandni, correct. You're right. Lakshmi, you're right. So that's the correct answer. So whenever we are planning for an auditory brainstem implant, now if we see, we have got the external ear, we have the middle ear, and then we have the inner ear. From the inner ear, we have the eighth nerve that takes the impulses to the brainstem. Okay. Now, whenever there is a pathology of the external ear or the middle ear, a hearing aid or a BAHA would be sufficient. So if there is a hearing aid cannot be used, you can use an BAHA. So for external and middle ear pathologies, what will you do? You will either give a hearing aid, and if the patient cannot use hearing aid because of external auditory canal atresia or tympanic membrane, there is a constant discharge and cannot put the hearing aid, and the patient cannot go for surgery also, or there is a middle ear hypoplasia. In that situation, if you cannot use a hearing aid, then comes BAHA, bone anchored hearing aid. So this is for external ear and middle ear pathology. Now, if there is an inner ear pathology where the patient can have moderate to severe hearing loss, you can use a hearing aid again. But if it is a severe to profound hearing loss, and the severe to profound hearing loss is bilateral, then you will go for a cochlear implant. So cochlear implant is used if there is a cochlear pathology which is bilateral and it is a severe to profound hearing loss. Now, if there is an eighth nerve pathology, now imagine there is a pathology in the eighth nerve. Can I put a cochlear implant? No, even if I put a cochlear implant, can the eighth nerve conduct the impulses? No. In that situation, I will have to put a brainstem implant. So what is the indication of a brainstem implant? Whenever there is a cochlear nerve pathology. And here in the brainstem implant, where will you put? You will put the implant in the recess of the fourth ventricle. That is the site of insertion of implant. Now, if they ask you site of insertion for a cochlear implant, where will you insert? The answer will be scala tympani of the cochlea. Now, scala tympani is entered through which window? It is entered through the round window. So, through the round window, you will insert the implant into the scala tympani. So I hope you understood the modes of rehabilitation based upon the hearing loss. If there is external ear, middle ear, hearing aid first. If hearing aid cannot be used, then you're going to go for BAHA. Unilateral severe to profound hearing loss, again BAHA. But if it is a bilateral, both the ear and severe hearing loss or profound hearing loss, then cochlear implant. If there is a eighth nerve pathology, then you're going to go for brainstem implant. Okay. Now let's go to the next question. High frequency audiometry is used in which condition? Otosclerosis, ototoxicity, non-organic hearing loss, or Meniere's disease. So where do you use a high frequency audiometry? So typically in audiometry, we start with 250 hertz and end around 8000 hertz. But if I'm doing high frequency, meaning I'm using 16,000 hertz, 20,000 hertz, or 24,000 hertz, if I use these frequencies, when will I use? Will I use this for testing otosclerosis or ototoxicity or non-organic hearing loss or Meniere's disease? In which condition are we using this high frequencies audiometry? So Chandni is saying D. What about others? I'm waiting for your answer. Yes, come on guys, answer this question. Ototoxicity is what Pratishtha is saying. What about others? The correct answer is ototoxicity. There are few indications when you're going to use high frequency audiometry. So typically when a patient is undergoing a treatment with ototoxic medication, like say anti-cancer drugs or with gentamicin or any or anti-malarials, and we are thinking that there is a possibility of ototoxicity, these frequencies will get affected first and later your other frequencies will get affected. So if I see there is an abnormality in the high frequencies, I know that the patient is slowly going to develop hearing loss. So either I need to alter my medication or I have to stop the medication so that the patient does not develop hearing loss in at least the speech frequencies, at least in this frequency which is necessary for our normal hearing of speech. So we do this for ototoxicity, or the other condition where we do it is NIHL, noise induced hearing loss. So those people who are working in an environment like in mining or aircraft industry, or they're musicians, or they're they go into discos where loud sound is there. So when we know that people are exposed to this loud sound and we know there is a probability of hearing loss, as a part of the occupational screening, we will do this high frequency audiometry and identify if there is any hearing loss that has developed, and if it has developed at the higher frequency, very high likelihood that he is going to have in the speech frequencies also. So we say to stop the exposure to sound, or if the patient has to go to that occupation, use ear plugs or ear muffs and then go to work in a noisy environment. So these are the two indications where we do a high frequency audiometry. The first one is ototoxicity, the second one is NIHL. Okay, the next question, very simple and easy question. Hyperacusis is defined as hearing only loud sound. Normal sounds are heard as loud and painful. Completely deaf state, ability to hear better in noisy surroundings. So what is the definition of hyperacusis? So Preetham and Lakshmi, ability to hear better in noisy environment is called as paraacusis wilsi. So if a patient hears better in noisy environment as compared to silent environment, we call this as paraacusis wilsi, and this is a feature of which condition? In otosclerosis. So in otosclerosis, you will see this paraacusis wilsi. So this cannot be the answer. Completely deaf state is hypoacusis. So this also cannot be the answer. Now, hearing only loud sound is not hyperacusis, but normal sound being heard as loud and painful, this is called as hyperacusis. Now, hyperacusis occurs whenever the stapedius muscle has got paralyzed. So, whenever there is a stapedius muscle paralysis, can it contract? No. If it cannot contract, will it allow excessive sounds to enter from the middle ear to inner ear? Of course, yes. And as a result, normal sounds will be heard as loud and painful. And this is seen, stapedial muscle paralysis will obviously be seen whenever there is a facial nerve palsy. So facial nerve palsy can present to you with hyperacusis, where normal sounds are heard as loud and painful. No problem, Preetham. It's okay to do mistakes, and we are humans. Everyone can err. You don't have to be feeling bad or sad about it. It's absolutely all right. Okay, in facial nerve palsy of the right side, stapedial reflex is absent on right side, on left side, on both, or it is not absent at all. Now, this is again a very simple, easy question. If you know the stapedial reflex pathway, then it's going to be very, very simple for you to answer. Yes, I'm waiting for your answer. So if there is a facial nerve palsy on the right side, the stapedial reflex will be absent on. Mustafa and Pratishtha say A, correct. That's the right answer. So if you see, the sound goes from the external ear to the middle ear. From the middle ear, it goes to the cochlea, which is your inner ear. From the eighth nerve, it goes to the cochlear nucleus. From the cochlear nucleus, there is decussation of fibers to the superior olivary complex on both the sides. So from right side, it will go to right and left, and from left side, it will go to left and right. So there is a cross decussation of fibers. From the superior olivary complex, via the facial nerve nucleus, via the facial nerve, via the nerve to stapedius, it will go to the middle ear and cause contraction of the stapedius muscle. So even if I give loud sound on one side, you will see contraction of stapedius muscle on both the sides. So this reflex is called as stapedial reflex, which is loud sound causes bilateral contraction of stapedius muscle. So this is about your first thing. Now, if there is a cochlear pathology, or if there is a eighth nerve pathology, or if there is a cochlear nucleus pathology, you will have bilateral loss of stapedial reflex, because on both the sides the impulses will not travel. But if there is a facial nerve pathology, only on that side, that ipsilateral side, impulses will not travel and we will see loss of stapedial reflex. So here they're asking to you facial nerve palsy on the right side, the stapedial reflex will be absent on the ipsilateral side. So that's the correct answer. Okay, now let's go to the next question. Initial screening test for newborn hearing with hearing disorder. What would be your screening test of choice? Auditory brainstem response, otoacoustic emissions, free field audiometry, or visual reinforcement audiometry. So what do you think is the screening test for neonates? This is again a very common question which you tend to get in the exam. What is the screening test? So there is a confirmatory test and there is something called as screening test. So for confirmation, what do you do? For screening, what do you do? Very good, Ayandas. Lakshmi, otoacoustic, sorry, Ayan and Preetham, it's not A, it is B. ABR is your confirmatory test. It is not used for screening. The screening test of choice is otoacoustic emissions. Otoacoustic emissions are the emissions coming from the outer hair cells of the cochlea. So from where are they coming? They're coming from the outer hair cells of the cochlea. So if these emissions are present, what does it mean? That the outer hair cells are functioning well, which in turn means that the cochlea is functioning well. But if these emissions are absent, does it tell you the cochlea is definitely flawed and abnormal? No. Then you'll have to confirm. The confirmatory test is auditory brainstem response, also called as BERA. Brainstem evoked response audiometry. So confirmatory is via BERA, screening is via otoacoustic emission. Okay. Let's go to the next test. Which of the following is not true of the following test? Induction of nystagmus by thermal stimulation. Normally, cold water will cause nystagmus to the opposite side and warm to the same side. In canal paralysis, there is no nystagmus. It stimulates the posterior semicircular canal. Now tell me, the question is asking you which is not true about the test that has been shown to you. I'm waiting for your answers. Yes, guys, quickly come on, answer. What do you think is the answer to this question? Yes, I'm waiting. So what do you see here? You see the patient is made to lie with a 30-degree head end elevation, and this 30-degree elevation is kept to make sure that the lateral semicircular canal gets maximally stimulated. Now you can see there is irrigation of water happening into the external auditory canal. Warm water and cold water is used. So 7 degrees above and below the body temperature. So 30 degrees centigrade and 40 degrees centigrade is used because our body temperature is 37. Now, when you irrigate the external ear with warm water or cold water, what will happen? Thermal currents go into the middle ear. Like if you take a glass of water and if it is warm water, if I keep my hand outside, I can feel those thermal waves, right? So those waves or that thermal current or convection currents will go to the middle ear. Now in the middle ear, we have the bulge of the lateral semicircular canal, and this will also get heated up or stimulated. Now when there is stimulation of the lateral semicircular canal, the impulses will travel via the superior vestibular nerve. From the superior vestibular nerve, the impulses will go to the vestibular nucleus. Now, from the vestibular nucleus, the impulses will go to the brainstem. Now, from the brainstem, there will be three efferents. The first efferent will go to medial longitudinal fasciculus, where you have third, fourth, and sixth nerve nucleus. So third, fourth, sixth, oculomotor, trochlear, and the abducens supply the extraocular muscles. And now when they are stimulated, it will cause nystagmus. So this test is called as caloric test, where thermal stimulation will cause nystagmus. So this is called as vestibulo-ocular reflex. So is this induction of nystagmus by thermal stimulation? Yes, that's the true statement. Now there is a rule for what kind of nystagmus and direction of nystagmus, which is remembered by cows. Cold water will cause nystagmus towards the opposite side and warm water will cause nystagmus towards the same side. So is this the correct statement? Cold water to opposite side, warm water to the same side? Yes. In canal paresis, so if this canal is not functioning well, will there be nystagmus or will there be no nystagmus? Of course, if the canal is not functioning well, there will be no nystagmus. So this is also true. But is it stimulating the posterior semicircular canal? No chance at all. It is stimulating the lateral semicircular canal. So that's your answer. So I'm hoping that everyone understood this concept of the test, which we call it as caloric test. Okay, great. Now let's go to the next question. A middle-aged diabetic with tooth extraction with ipsilateral swelling over the middle third of the sternocleidomastoid and displaced tonsil towards the contralateral side. What is the diagnosis? Parapharyngeal abscess, Retropharyngeal abscess, Ludwig's angina, none of the above. So there is a patient who is diabetic. The patient is also having history of tooth extraction. After tooth extraction, meaning the infection is coming from the gums, from the teeth, from there the infection is going on the ipsilateral sternocleidomastoid, and there is also displacement of tonsil towards the opposite side. So what do you think is the cause for this? Is this parapharyngeal, retropharyngeal, Ludwig's, or none of the above? So Preetham, if you say none of the above, that's not the answer. Unfortunately, you can make another guess if you want to. No problem. I have given you one chance. You can take the second chance and tell me what do you think is the answer. Yes, I'm waiting for your answers. Okay, so Virender Pratap says C. So Virender, if it is Ludwig's angina, you will see cellulitis here in the floor of the mouth, and you will see definitely this is secondary to tooth extraction, dental infections is right. But why would you see a swelling on the sternocleidomastoid, and why would the tonsil be displaced? In Ludwig's, we see cellulitis of the floor, tongue is displaced up, but we don't see tonsillar displacement, right? Yeah. Okay, Pritam. So I'm sorry that I mistook your answer. So okay, fine. That was for previous question. For this question, can you tell me what's the answer? So for this question, the answer is parapharyngeal abscess. So whenever they give you a question where they're telling you that there is a displacement of tonsil, so the right tonsil has got pushed towards the opposite side or to the contralateral side, there are two differential diagnoses that you should know. So unilateral displacement of tonsil, you should be sure of two things. The two things are, the first one is this a peritonsillar abscess or is this a parapharyngeal abscess? So is this peritonsillar abscess or is this a parapharyngeal abscess? Now, both of them will present to you with unilateral displacement of the tonsil. In peritonsillar abscess, there is no neck swelling because the peritonsillar space doesn't extend into the neck. It is limited only to the tonsil. But parapharyngeal space extends up to the greater cornua of the hyoid bone. So if there is any swelling in this abscess, it will present to you as a bulge in the upper third of the sternocleidomastoid. So parapharyngeal abscess will present to you as a bulge of sternocleidomastoid muscle in the upper third. So here there is a bulge of the sternocleidomastoid, unilateral displacement of the tonsil, which is why the answer is parapharyngeal abscess. Now, if they would have given you a question that there is a diabetic presenting to you with a swelling on the posterior pharyngeal wall on the side of the midline, not exactly in the midline, but in the paramedian position, then your answer would be retropharyngeal abscess. But if they would have given to you a midline swelling, not on the paramedian position, but a midline swelling, then your answer would be prevertebral abscess. So in your oropharynx, if you see tonsillar bulge, two differential diagnosis, peritonsillar or parapharyngeal. On the side of midline, retropharyngeal. In the midline, prevertebral. So if this is known for you, you will be able to answer the question. Okay, let's go to the next one. Which of the following fractures is most commonly associated with CSF rhinorrhea? Leafort 1, Leafort 2, Leafort 3 or pyramidal fracture? So which fracture is commonly associated with CSF rhinorrhea? So I'm waiting for your answers. Meanwhile, I'll draw one diagram for you to understand what is Leafort 1, what is Leafort 2, what is Leafort 3. Yes, I'm waiting for your answer, guys. So which commonly is associated with CSF rhinorrhea? Is it Leafort 1, 2, 3 or pyramidal fracture? C is correct answer, Ayan. Virender, it's unfortunately not B, it is C. So what is Leafort 1 fracture? The fracture goes from the floor of the maxillary sinus and floor of the nose. So this is the floor of the nose. This is the floor of the maxillary sinus. This fracture is called as Leafort 1. So is this anywhere in close proximity to the CNS to cause CSF rhinorrhea? No. So Leafort 1 cannot essentially cause any CSF rhinorrhea. What is Leafort 2 then? This Leafort 2 starts from the nasion, goes from the medial wall of the orbit, floor of the orbit and the maxilla like a pyramid. Nasion, medial wall, floor, maxilla. So it's called as the pyramidal fracture, which is Leafort 2 fracture. Here it might cause, might not cause. There is no definite evidence that it can cause CSF rhinorrhea. But what is Leafort 3? Leafort 3 goes from nasion, medial wall, floor, lateral wall and zygoma. So nasion, medial wall of the orbit, floor of the orbit, lateral wall of the orbit, zygoma. This is called as craniofacial disjunction. This is called as craniofacial disjunction. So here, if you have a craniofacial disjunction where the cranial cavity has got separated from the facial skeleton, then will CSF rhinorrhea most commonly occur? Yes. So this is your Leafort 3 or craniofacial disjunction where you have a highest possibility of having CSF rhinorrhea. So the answer is 3, which is Leafort's 3 fracture. Okay, let's go to the next question. Appropriate treatment for an acute stable hematoma of the pinna of the ear include which of the following measures? Ice packs and prophylactic antibiotics, excision of the hematoma, needle aspiration, incision and drainage, and pressure bandage. So here they're telling that there is a acute stable hematoma of the pinna. What will you do? Will you just put ice pack? Will you just excise, or will you aspirate, or will you do incision and drainage and pressure bandage? What will you do? Yes, I'm waiting for the answers from all of you. So whenever there is a hematoma of the pinna, which we call it as hematoma oris, very good, Ayan, you have to definitely drain that hematoma. So you will do incision and drainage, but the most important is to prevent reaccumulation. You will have to put a pressure bandage. If you do not put a pressure bandage, there will be reaccumulation of hematoma. So it is not just IND or aspiration. You will have to definitely do IND. You will have to put a pressure bandage, start on oral antibiotics, so that there is no infection of the cartilage or necrosis of the cartilage, because if there is an infection or necrosis, it can result in deformity of the pinna. So for acute stable hematoma of the pinna, you will do incision and drainage and pressure bandage. Okay, the next question. A female patient presented with decreased ability to smell. On examination, there is a large nasal cavity with foul smell coming from her nasal cavity. CBC showed microcytic anemia and serum vitamin D levels are low. What is the most likely organism that is most likely causing her this disorder? Is it Pseudomonas? Is it Klebsiella? Is it Proteus? Or is it Haemophilus influenza? So there is decreased ability to smell, large nasal cavity, foul smelling nose, anemia, low vitamin D levels. What are we talking about? Which condition? Very good. This is atrophic rhinitis. Very good, Preetham, Lakshmi, Aishwarya. The correct answer, Ayan, yes, is B. So we are talking about atrophic rhinitis, where you see atrophy of the mucosa, of the turbinates, of the sinus, of the olfactory epithelium also, because of which they have decreased ability to smell. And there is a large nasal cavity because everything has gone atrophic. And there will be large crust coming in the nose, foul smelling coming in the nose, but the patient himself cannot smell it, which we call it as merciful anosmia. CBC showing microcytic anemia and vitamin D levels are low. So microcytic anemia and vitamin D levels which are low favor the growth of an organism which is called as Klebsiella oziana. So Klebsiella oziana is the organism responsible for causing this atrophic rhinitis. Very good. I think everyone knew this, so I'm going to go quickly to the next question. A 20-year-old male presents with severe congestion inside her left nose, and he has history of recurrent congestion. He used over-the-counter decongestant drops every time. This hint is enough for you to know one diagnosis. What should be done in this patient? Intranasal antihistamines, stronger decongestant drops, intranasal corticosteroids, continue decongestant sprays. So what are we discussing here? A patient is having congestion of the nose, history of recurrent congestion, history of use of chronic use of decongestant nasal drop. We are talking about rhinitis medicamentosa. So for rhinitis medicamentosa, which happens due to abuse of over the counter medication or decongestant nasal drops, what is the treatment for this? What will you do? See, intranasal antihistamines is definitely not used for rhinitis medicamentosa. You will definitely discontinue this decongestant, or you will not use the decongestant. Here, what happens in rhinitis medicamentosa is because of excessive abuse of the alpha adrenergic agonist drug, which is xylometazoline or oxymetazoline. There is down regulation of the receptors. The receptors are no longer active and functional like how they used to be in the first use. So they have been down regulated. So to up regulate or increase the activity of the receptor, we have to give a steroid. Now I have a choice of either systemic steroid or an intranasal steroid. Which one would I prefer? I will not prefer systemic steroids because of its potential adverse effects. I will choose an intranasal steroid because that is going to give me the treatment that I want, that is upregulation, and it is going to potentially lower the adverse outcomes. So intranasal corticosteroids will be the treatment of choice for rhinitis medicamentosa. So with this, I finish my session. I hope this session was of benefit for all of you. I try to cover the maximum important topics in this session. We are going to have more sessions coming this month your way. And if you like my classes, do join and log into my classes. And if you got any queries, do comment in the chat box below, and I'll be more than happy to help you. I'll take a leave from all of you, and I'll see you all again. Until next time, take care and bye bye. Lots of love and good wishes to all of you, that you keep studying, keep reading, stay motivated, and to be able to achieve the seat of your choice in the end. So with best wishes from me, I take your leave. Dr. Vaishnavi saying goodbye.